Okay, let's get started with part 2 of an integrative approach. So again, this gap in time that can be too long for some patients, ongoing symptoms, I'm going to talk a little bit more. This section I'm going to talk about supplements, which generates a lot of interest and a lot of questions. So I think people are going to enjoy the supplement section. I'm also going to talk about mind-body therapies, which I think is quite misunderstood and not really recognized how important it can really be. The timer hasn't started. Waiting for better, let's focus on what we can do. And as I said, we're going to talk about supplements and mind-body medicine and how that might play a role in improving the situation for patients with persistent symptoms. So just a little bit of general background on supplements, to mention that there are different categories of supplements. There are nutritional supplements with the vitamins, minerals, amino acids, fatty acids like fish oil, fiber, that are obviously popular and generally have a very wide margin of safety. Botanicals are supplements that come from plants. They may be food-based like green tea or pomegranate, or they may be from herbs like curcumin or ashwagandha. Because botanicals tend to be are often concentrated extracts, not always, and they can actually have more issues with drug interactions and side effects. So they need to be used a little bit more cautiously. Probiotics are another class of supplements. So the big question from many patients is to supplement or not, and how do you decide if you need a supplement? And the first thing that I would say is that keep in mind supplement means supplement. It's an add-on therapy, and add-on therapies have much more benefit if the fundamentals are in place, if the diet is already really quite good and the other lifestyle interventions are in place. And if that foundation is in, then a supplement as an add-on therapy might have benefit. But certainly the need needs to be evaluated. I once had a patient come to me with a chief complaint of needing help to reduce her supplements. She was 76 years old and she was on 78 different supplements and taking over 300 supplement pills a day. So I don't think she needed all of those. And it took me quite a long time to go through the list. And I was really kind of surprised that she had no evidence of adverse effect from all of those. But because she was on a massive amount of calcium and magnesium, it was probably binding to a lot of the supplements, so she wasn't absorbing most of it. But anyway, need is important. And if there seems to be a need for a specific supplement, I think a careful evaluation of the evidence of being effective and the evidence of being safe. As I mentioned, most dietary supplements have a wide margin of safety, but they're not universally safe. So being aware of any potential side effects or contraindications, and knowing that there can be interactions with other supplements or medications, and particularly the botanical supplements have a little bit more issue with interactions. And because of the safety issues, I think reviewing supplement use with your physicians, I think there's a tendency to not disclose that you're taking supplements because some physicians are a little bit negative about the use of supplements or perhaps not very familiar with them. But I think it's still important to at least mention that you're taking a few things so that there's an awareness. So supplements, I definitely think there's a role for supplements if they're used judiciously and you're not taking 76 or 78 different ones, and just by evaluating the above indications. Surgery and procedures, something that SIH patients do have. I think that most supplements do need to be discontinued before surgery for safety. Many have blood thinning issues, others have issues with interacting with anesthetic agents. So it's usually safe. I mean, something like vitamin C you wouldn't need to worry about, but most supplements do need to be stopped. So sourcing dietary supplements, I think, can be very challenging. The dietary supplement industry is not particularly well regulated. There are a lot of issues with quality, potency, and purity. Really kind of a lot of dangerous stuff out there. There are a lot of supplements, particularly from China, that are adulterated with unlisted ingredients, which can be quite dangerous. Some botanical supplements can be contaminated with heavy metals, which you clearly don't want. Patients who have allergies or chemical sensitivities have to read the fine print and make sure that those extra ingredients aren't going to cause a problem for them. So one sort of basic guide that will assure you of some basic level of quality are these three labels: NSF, USP, and Consumer Lab. And those three testing organizations place seals on supplements, and that gives you assurances that the minimum manufacturing standards have been met, that the listed ingredients are there in the appropriate amount, and testing for contamination has been done. So that gives you a bit of a margin. It doesn't really tell you if the particular supplement is going to be effective or safe for you, but at least you've ruled out some of the big issues. So I'm going to talk about 3 common nutrient deficiencies, probably the 3 most common nutrient deficiencies that I've seen in practice in integrative medicine and in general medicine. And these 3 nutrient deficiencies are particularly relevant to patients with SIH or patients with pain because they all impact the brain and they all impact pain. So they can have some value. So first, I'm going to talk about magnesium. Magnesium is a major structural component of the bones, the skeleton, so it plays a major role there, and that's where most of your magnesium is. There's a fair bit in muscles, a little bit in other cells, but very little of it is in body fluids and blood. In plants, magnesium is very important because it's the center part of the chlorophyll molecule. So any green plant, you know it's got magnesium in it. Remember to eat your greens. The functional roles of magnesium, a very long list. Magnesium is under-recognized for its importance, I think, and forgotten how important it is. But really, if you look at this list, 325 essential metabolic reactions. And some of the more important ones are energy production, energy storage, think fatigue. Certainly inadequate magnesium levels can contribute to poor mitochondrial function. The synthesis of neurotransmitters is important, and obviously that plays a role in brain issues and pain. Transport of calcium and magnesium across cell membranes is how nerve conduction happens. So again, brain and pain. Muscle contraction, same thing, and heart rhythm. So pretty important in combination with calcium. It also plays a role in cellular signaling and cellular migration, which is important in tissue healing. So the symptoms, long list of symptoms, really is a reflection of how many functional roles magnesium has in the body. And if you look at this list, a lot of these symptoms are fairly nonspecific. A lot of these symptoms are symptoms that patients with SIH will have, but you don't want to add on a magnesium deficiency on top of SIH. Certainly anxiety or depression, worsening headaches, fatigue, weakness. These are things we want to avoid making worse. So the main causes of magnesium deficiency that are relevant to intracranial hypotension patients is inadequate intake. In fact, the RDA for magnesium for adult men is 420 milligrams, for adult women 320 milligrams. And if you're eating a really healthy diet and you don't have any issues with nausea or vomiting, that's reasonably easy to get. But despite that, 2/3 of Americans don't get that amount, and 1 in 5 don't even get half. So inadequate intake is an issue, and of course, as I mentioned, compounded by nausea for many patients. The other reason that SIH patients are at risk for magnesium deficiency is that magnesium is depleted from stress. And I think most SIH patients are under physiologic stress from the pain and whatever's happening to their brain from that loss of CSF. I've listed some of the other, common sense reasons for magnesium deficiency: losses from diarrhea, losses from urinary losses. I've listed here that diuretics, which increase your urinary flow, can cause magnesium deficiency. Just remember that acetazolamide, used for rebound high pressure, does deplete magnesium, and very few physicians actually pay attention to this and address it. It's important because it can make you feel pretty crappy. Losses from exercise are there too. Medications, the proton pump inhibitors used for acid reduction, are well established to cause magnesium deficiency. But again, in the SIH patient, focusing on getting enough intake and considering it as a deficiency and addressing it. Magnesium in patient care has a lot of research behind it. It's used in a very long list of clinical situations, as I've listed here, which you can read yourself. I don't need to read them. I'll just point out that pain and brain, I'll keep saying that, pain and brain are impacted by magnesium. There's well-established evidence for the prevention and treatment of migraine, using migraine. It's a high-grade level evidence. It's used pretty often in postoperative pain by integrative pain management physicians. There's research in other pain. Has a clear role in impacting the severity of pain and the brain, anxiety, depression. So important. Unfortunately, testing for magnesium deficiency isn't usually very helpful. We use it. The serum magnesium test misses most cases, primarily because most of the magnesium is not in the blood. The red blood cell magnesium, which is an intracellular magnesium, is a little bit more helpful, but really still not that great. So practically speaking, what we do in assessing someone for magnesium deficiency is really look at the clinical situation. Are there risk factors for deficient? Is it likely they're deficient? Do the symptom profiles fit? And if that's the case, then we try to either boost the dietary intake or even add a supplement. So this photograph, I think you can see it okay. It includes foods that are particularly high in magnesium. And the food that's the highest in magnesium is dark chocolate. Which is really good when you're bedridden, to eat dark chocolate. It's interesting, some clinicians think that the craving of dark chocolate has to do with your body figuring out that you're low in magnesium. I don't know if there's any way to prove that, but it's an interesting theory. So I like chocolate. Nuts are high in magnesium, and that's an easy thing to eat if you're stuck in bed. Note that I've got a variety here. Several kinds of seeds, also high in magnesium. Here we've got lentils, black beans, other types of beans. So beans and lentils. This are our grains, is black rice, brown rice, red rice, white quinoa. This sort of variety sort of emphasized the importance that I was mentioning earlier about variety of colors and variety in your diet to improve how many phytonutrients you're getting. I mentioned magnesium is the center part of chlorophyll, so dark leafy greens are really high in magnesium. So if you want to boost your magnesium intake, focus on these foods. And when magnesium supplementation is being considered, and certainly for any patient with pain, I do consider it. It's really a very safe thing to do unless you have impaired kidney function. Some patients with cardiac conduction abnormalities or arrhythmias need to clear it with their cardiologist. But for most people, it's very safe. For a few patients that are taking gabapentin for pain management, just separating the dosage by 2 or 3 hours is fine. It just tends to bind to it and impair the absorption. It's avoided in patients using gabapentin for seizure disorders because you don't want to lower the blood levels. I don't believe in megadosing much of anything. I think it throws the balance of nutrients off. Nutrients work in networks. For magnesium, calcium, magnesium, vitamin D, vitamin K work together. In terms of what kind of magnesium to take, different types of magnesium have different absorption. Magnesium oxide tends to be very poorly absorbed and usually results in diarrhea. So you're not really much point in taking it if you're not going to be absorbing it. Magnesium citrate is a little bit better absorbed, and I might use that in someone who's prone to constipation. Better absorbed forms, there's several of them out there. My personal favorite is called dimagnesium malate. It's 2 magnesiums attached to each malate. Just means that the pill is a little bit less bulky. I just wanted to mention that you can actually absorb magnesium through your skin. Epsom salt is magnesium sulfate, a cup or 2 in the bathtub. Soak for 15 minutes and you'll get a really good sleep. So moving on to vitamin D. Vitamin D is converted to calcitriol, which is a very important hormone in the body, at least as important as insulin. It's been around forever. Almost every cell in the body has vitamin D receptors. We don't have receptors on cells unless we need them. Over 2,000 genes are affected by vitamin D. It has widespread effects. There's really no debate in the scientific community about the widespread importance of vitamin D. The only thing that's debated is what level you should have for general health, even though there's a massive amount of data to give us the answer to that. So vitamin D deficiency, most of us know that severe deficiency in children is called rickets. The bones are demineralized and soft, so you get this bending. This is called a windswept appearance. Quite often we see the bowing of legs, and with time that can be reversible, but it's not a very good thing to have happen. When adults have severe deficiency, they have bony tenderness that you can pick up on the shins. Low bone mass, of course, has other causes other than vitamin D deficiency, but is the sign. But for mild to moderate vitamin D deficiency, the vast majority of people have no symptoms whatsoever. And in fact, it's a long latency problem. You don't get into problems with vitamin D deficiency if you're deficient for months or even a year or 2, but once you've had vitamin D deficiency for many years or decades, you really start to increase your risk of chronic disease. Some of these other symptoms are fairly nonspecific, so it's easy to see how it might be overlooked or not discovered. So the relevance for vitamin D in the brain, and I keep talking of brain and pain because those are priorities as far as I'm concerned for an SIH patient, even though vitamin D has many widespread effects. I'm focusing mainly on brain and pain. So vitamin D with the brain, we know that I mentioned the long latency of vitamin D. Long-term deficiency increases the risk of cognitive decline and dementia, increases the risk of multiple sclerosis. Unfortunately, treating with vitamin D for those things after the fact doesn't really have much of an effect, probably because it's been a long latency and multifactorial disease. Still, most MS neurologists do correct vitamin D deficiency in MS patients, but the data doesn't really support that it makes a huge difference once it's established. Traumatic brain injury is interesting. Traumatic brain injury patients who have a low vitamin D level at the time of their injury have much poorer neurologic outcomes. They're doing a bit of research on combining vitamin D with other things to improve outcomes, and there is a little bit of positive data there, but it's very early. And of course, vitamin D is thought to play a role in depression and autism, but the exact issues with that are not really very clear. When it comes to vitamin D and pain, there's a very high prevalence of vitamin D deficiency in patients with chronic pain. Surprisingly high. We don't really understand why vitamin D affects pain, but we know that it works. We know that if patients are vitamin D deficient in pain and we treat the vitamin D deficiency, they do better. So vitamin D supplementation, is something I think is really important in anyone with any kind of pain and with many chronic diseases. It really needs to be guided by labs. Sorry. It really needs to be guided by lab testing, which is easy to do, it's reliable, it's inexpensive. There are a few cautions, but those aren't particularly common. Your physician will be familiar with them. So the reference range of 30 to 100 is a well-established evidence-based reference range. For anybody from Canada, the conversion is 2.5. You can see it there, 2.5. So you can easily convert. The absolute minimum for bone health is 30 nanograms per ml. But for most other diseases, you need a little bit higher levels, between 40 and 60. And that's the range that I recommend for patients who have pain. So moving on to omega-3 fatty acids. Omega-3 fatty acids are well known to be often deficient. It's difficult to discuss omega-3 fatty acids without talking a little bit about omega-6 fatty acids, because those two work together in concert and in balance. The two essential fatty acids that we have, essential fatty acids meaning you must ingest them to live because your body can't manufacture them, include linoleic acid, which is an omega-6, it's a short chain omega-6, and ALA, which is the short chain omega-3. These are pretty widespread in foods and fairly easy to get. Both of these are converted to other omega-6s or omega-3 fatty acids. The difficulty with the omega-3s is that while you may have a fair bit of this around in your blood, the conversion to the longer chain omega-3 fatty acids, EPA and DHA, is very inefficient in humans, and levels of EPA and DHA are so often low that for many nutritional experts, they consider them conditionally essential, meaning that you should get them in your diet as preformed EPA and DHA. So why are omega-3 and omega-6 fatty acids important to health? This is a really important slide. It's a simplified diagram of the cellular membrane, and you can see that there's little phospholipids with two little fatty acid tails all pointed together, and you have protein channels and all kinds of receptors in the cellular membrane. The health of the cellular membrane depends upon the health of the fatty acids that are in there. The cellular membranes needs to be fluid enough, but not too fluid. And so really, without a healthy cellular membrane, it's really difficult to have normal cellular function and good health. And in the brain, that's particularly important. So cellular membrane structure means that cellular membrane cellular function is going to be impacted. So we need both omega-6 and omega-3 fatty acids, but as I mentioned before, it's the omega-3, the long-chain omega-3 fatty acids that many of us don't have enough of, so supplementing it becomes important. And beyond the cellular membrane, which is fundamental to good health, the omega-6 and omega-3 fatty acids are metabolized into chemical messengers that have a lot of really important roles in inflammation and immune function. Tissue healing requires some inflammation, but not too much inflammation. So you need some, but you just need the right amount, the Goldilocks principle. And having that balance is important. These fatty acids also regulate cell growth and division and blood clotting. Pretty widespread roles in good health come down to having adequate fatty acids and having them in a ratio that keeps that balance of inflammation at the right level. So when it comes to omega-3 fats in the brain, I mentioned that those cellular membranes are important. The brain needs a particularly high amount of DHA, which was the longer chain omega-3 fat, difficult to get from conversion from plant sources. As you can see, there's a long list of roles that the omega-3 fats play in the brain. But just keep in mind that for brain structure, brain volume, and brain function overall, omega-3 fats are essential. There is a very large volume of research on omega-3 fats and brain health. For depression, the data is pretty strong that omega-3 fatty acid levels will affect the risk of depression, and correcting low levels will have a favorable impact. They're also used in cognitive impairment and dementia, although in those situations, if the disease is not more than early, usually you need to use combination therapies with other things and not expect monotherapy or a single therapy with fish oil to help. Traumatic brain injury, there's also some data that omega-3 fats can make a difference, but again, the numbers are small. So when it comes to omega-3 fats and pain, again, there's quite a bit of data to tell us that omega-3 fats modulate pain through a number of pathways. Many of them are inflammatory pathways, but there really are quite a few pathways that are affected by adequate omega-3 fatty acid levels. The studies that have a lot of data include patients with rheumatoid arthritis, painful periods, myofascial pain, back pain, diabetic neuropathy. I've mentioned chronic daily headache here, and interestingly, using fish oil supplements isn't very effective, but if you take your diet, reduce the omega-6 fats and increase the omega-3 fats, you have a very favorable effect, and that's high-level evidence. So again, it's that balance of omega-3 to omega-6. So as with any nutritional component, it's always best to get what you can from diet. But with the long-chain omega-3 fats that I mentioned, that poor conversion of the plant-based into EPA and DHA is poor, so it's usually a good idea to supplement with those too. And if you're vegans, can obtain that from marine algae in a supplement form. They can't really get it in their diet. They can get ALA in their diet, but they can't get the EPA and DHA unless they supplement. For those that are omnivores, consuming fish is a good source of EPA and DHA, and fish oil also has both of those components. And for most, a dosing of about 1 gram of EPA plus DHA is good if you have pain. But in cases where patients are really health challenged, I think it's worthwhile to consider lab testing because it can help you to guide, how low those levels are and how much you need to replace. So just a reminder that with those 3 things, magnesium, vitamin D, and fish oil, those really are 3 fundamental nutrient deficiencies that I think about in patients with pain, and I think it obviously applies to SIH patients. And those supplementations are safe, and obviously use lab monitoring where I've indicated it's helpful. So curcumin. Curcumin is a botanical supplement. It's the most studied botanical of all time. There have been clinical trials in a really long list of diseases. And I know this is a busy slide, and it really is just to point out that curcumin affects a whole lot of molecular pathways. I have a document that's many pages long that actually lists all the individual pathways under each category. So it does a lot, but pointing out the things that are particularly of value to an SIH patient is anti-nociceptive, means it has an effect on pain, and neuroprotective helps the brain, and wound healing. There is an effect on wound healing. So those are things, again, pain, brain, and wound healing. So human clinical trials on curcumin, the total patient numbers are still pretty small if you compare them to studies with the 3 nutrients that I was just discussing. So keeping in mind that the patient numbers are still small, we still have some pretty good evidence that curcumin is helpful for the brain. It is involved in cognition, anxiety, and depression. There's good data. When it comes to curcumin and pain, it has effectiveness in osteoarthritis, rheumatoid arthritis, post-op pain, delayed onset muscle soreness. And I read a recent study using a combination of omega-3 fats with curcumin. And interestingly, they compared omega-3 fats or curcumin alone, either one alone, or the combination. It was only the combination that had a favorable effect. So that sort of goes along with combination therapies often being better. If you're going to supplement with curcumin, be aware that the average curcumin supplement may not be very good quality, and it may not be very well absorbed. There are a number of enhanced bioavailability formulations that I can talk to people about at the break if you're interested. Generally, they're pretty safe, but because so many molecular pathways are affected, there's always a risk of drug interactions, so keep that in mind. Curcumin also is one of those supplements that must be discontinued before procedures because of the blood thinning effect and also the potential for drug interactions. And anyone on blood thinning medications can't take curcumin because of that effect. But I think, curcumin is worth considering for someone that has significant pain, and in my experience, it can make a really big difference in downregulating that pain and dropping it a point or two on the pain scale. So I would love to talk about a whole bunch more supplements and nutritional things, but I don't have time. So I'm going to move on and talk a little bit about mind-body approaches, which I think are under-recognized in their importance. I think most SAH patients feel like this. So, what is mind-body medicine anyway? I think there's a lot of confusion about it. And the way that I try to simplify it is to just remind people that the autonomic nervous system has two arms. It has the stress response and the relaxation response. So the stress response is called sympathetic activation, and the relaxation response is called parasympathetic activation. And of course, you're pretty familiar with what happens with stress: increased heart rate, blood pressure, respirations, and the opposite with relaxation. So really, we know that the autonomic nervous system plays an important role in regulating all aspects of health, and that when we spend too much time in sympathetic activation and not enough time in parasympathetic activation, it influences many aspects of health. So mind-body medicine really just works through activating the relaxation response. That's what they all do. Regardless of the type, the approach, they all work through the relaxation response. So it's really actually not all that complicated. So interestingly, the parasympathetic nervous system is controlled primarily by the 10th cranial nerve called the vagus nerve. So the vagus nerve influences parasympathetic activation or the relaxation response. And there's been a lot of research done on the vagus nerve over the past couple of decades in particular. It really has very widespread regulatory roles, as I've mentioned, in autonomic function, because we're modulating the autonomic nervous system to impact health. And notice here, neurology, pain, mood, inflammation, memory, all things that we're kind of concerned about. So vagus nerve stimulation is really kind of high-tech mind-body medicine. It can be done invasively, it can be done non-invasively, and I'm just pointing out that there's a lot of research on vagus nerve stimulation and how it can affect health. Primary headache disorders are now well studied, and in fact there are a couple of experts in the next room that are experts on the use of vagus nerve stimulation in headache disorders. I wanted to show you this device, no relationship with them. It's a non-invasive stimulation device on the vagus nerve. This one is called a gamma core, and it was approved earlier this year for cluster headache, for management of cluster headache, and it's really quite effective. This particular device is approved for use in other countries, and the indications are a little bit broader. But keep an eye on if you see some information on that, keep an eye on it. It's likely that the indications, the different types of headaches that it'll be approved for, is going to broaden over the next few years. So we know, partly from some of this vagus nerve stimulation data and from a very large body of research on mind-body medicine, that mind-body approaches have a really widespread favorable effects on the body. You can see pain, sleep, brain issues, tissue healing, all impacted because you're modulating autonomic function. You're trying to correct that imbalance between sympathetic activation, the stress response, and parasympathetic activation, the relaxation response. So I think I went too far. So the secret with mind-body therapies is there really are a lot of different types of mind-body therapies, and I don't really have time to go into specifics of these ones, but just indicate that it's worth exploring a range of therapies to figure out what resonates with you. Breathwork is very easy to do. It just involves breathing more regularly, slowly, and deeply. There are a number of different techniques like Andrew Weil's 4-7-8 breathwork that you might want to look up. Meditation has a lot of data, but many people think that that's a little bit weird. I know engineers love biofeedback because it's very technical. So, but often patients don't realize that prayer is considered a mind-body therapy. And disclosure and journaling, if you're spending some time online talking about your experiences, that's actually a mind-body medicine. Mindfulness, chopping your garlic in a very nice way. So mind-body therapies are because the effects are so widespread and important, that I think they're worth most of us spending a little bit more time exploring 1, 2, 3, or 4 different ways of doing it. And this slide just reminds us that there are many things we do that aren't classified as mind-body approaches, but have a mind-body component. So yoga, tai chi, qigong, massage, all have a mind-body component and promote the relaxation response. And really anything that you do to relax has a mind-body component. If you're snuggling with your kitties or you're doing adult coloring, which has a meditative quality, these all have a beneficial effect in activating the parasympathetic or the relaxation response, and therefore have an impact on health. So I just want to emphasize as I start to wrap up here that think about combining a bunch of different approaches to make a difference, not only for pain, for your brain, and for tissue healing, but also for general health. This is a summary slide that just emphasizes the fact that I think that paying some attention to nutrition, physical activity, and mind-body therapies can impact these things that we've been talking about, pain, brain, and tissue healing, and are probably worth making some tweaks to see if that can make a difference for you. So back to this, list of integrative approaches for patients with SIH. Of course, the mainstay of treatment is it's an anatomic problem that requires an anatomic fix. While some people will get better spontaneously and have an easy result and get better quickly, for the smaller percentage of people that have ongoing symptoms, I think it's worthwhile looking at all of the things, using all of the tools in the toolbox, including the ones that I've talked about, but in addition, looking into some of the other options while we're waiting to improve. And this slide really just wanted to say a few words about the fact that over the last 10 years that I've been collaborating a little bit with Dr. Shivink and working on trying to impact things with intracranial hypotension. I've really seen that patients are being diagnosed much more quickly than they were 10 years ago, and I think that's attributable to increasing awareness and education. I've also seen that imaging is more refined, treatments are more refined, and a higher percentage of people seem to be getting better sooner. It doesn't mean that everyone is getting there, but I'm seeing progress, and I think that there's going to be more progress. And certainly having this symposium, having patients, caregivers, and clinicians all gathered together, I think it's a good sign that some of the work that we can do together can help to close these gaps a little bit more quickly. So that's the end. We're going to save questions until an afternoon question and answer period. So save your questions from there. But if you'd like to just approach me at break or at lunch, feel free to do so. The other thing I would mention is that my foundation business card is at the exhibit table. So it has my email address. If you don't have time to connect with me today and you just want to send me an email, I certainly invite you to do that. So that wraps up.